You're mid-sentence, and a name you've known for 20 years simply isn't there. After 60, that blank feels like a warning. But your hippocampus loses roughly 0.5% of its volume every year, and proper name retrieval drops nearly 30% in cognitively healthy adults. Normal forgetfulness and genuinely concerning memory decline are not the same process. The difference is more precise than most people realize, and it hinges on one distinction. Magnetic resonance imaging has made it possible to measure changes in the brain's memory center with precision. After age 60, the hippocampus, the structure responsible for forming and retrieving new memories, shrinks by about 0.5% each year. This figure comes from a meta-analysis of over 2,000 adults, confirmed by longitudinal studies that track the same individuals across a decade or more. Most people will not notice a single year's change, but over 10 years, the cumulative effect is measurable. This atrophy is not uniform across the brain. The hippocampus is especially sensitive to aging, while other regions maintain their size and function longer. Alongside structural changes, the speed of mental processing slows in nearly everyone past 60. A large cohort study published in Nature Neuroscience followed more than 2,000 adults between 60 and 85 years of age for a full decade. Over 95% showed a decline in processing speed, measured by reaction time and symbol matching tasks. The average annual loss was about 0.5% from each person's own baseline. This slowing did not predict later dementia or conversion to mild cognitive impairment. It was present in healthy adults regardless of education, cardiovascular health, or genetic risk. The biological explanation is straightforward. As neurons lose some of their connections and supporting cells thin, signals travel more slowly. The information is still there, but retrieval takes longer. Everyday experiences, such as searching for a name or the right word, reflect this change in speed, not a loss of stored knowledge. These facts anchor the experience of normal forgetfulness in quantifiable, age-related processes rather than in disease. Older adults often notice that it takes longer to bring a name or fact to mind, but the information itself remains intact. This pattern is not a sign of decline in knowledge. Instead, it reflects how the brain adapts to age-related changes. Functional MRI studies, including a meta-analysis published in Neuropsychology Review, show that people over 60 recruit both sides of the prefrontal cortex when solving reasoning or memory tasks. This phenomenon is known as the Herald model, hemispheric asymmetry reduction in older adults, and it acts as a built-in backup system. Dr. Roberto Cabeza, who helped define the Herald model, explains that older brains light up both sides of the prefrontal cortex to keep memory performance steady, even as processing slows. This compensatory activation allows older adults to maintain performance levels on knowledge-based tasks, even as reaction times lengthen. The effect size for this benefit, measured by Cohen's d, is approximately 0.4, a moderate and reliable advantage. The ability to draw on both hemispheres helps explain why vocabulary, general knowledge, and judgment do not just persist, but can actually improve with age. Data from the Health and Retirement Study, which tracks thousands of participants over decades, show an average annual increase of 0.2% in vocabulary scores after 60. Crystallized intelligence, skills, and knowledge accumulated over a lifetime remain stable or grows, while fluid abilities like rapid problem-solving slow down. The brain's capacity to compensate means that a slower pace is not the same as weakness. Everyday word-finding lapses or slower recall are often the result of retrieval taking a longer route, not a loss of the information itself. This distinction is essential for separating normal aging from early disease. As the story moves toward clinical thresholds, the evidence remains clear. Most memory lapses after 60 reflect adaptation, not failure. Not every memory lapse carries the same weight. The difference lies in how these moments affect daily life. Occasional forgetfulness, such as misplacing reading glasses, losing track of a conversation after an interruption, or searching for a word that comes back later, is a normal part of aging. The original clinical definition, first published by Dr. John C. Miller in 1962, described benign senescent forgetfulness as memory lapses that happen no more than once a week and never interfere with activities of daily living. These are the lapses that resolve on their own. The person remains independent, manages medication, appointments, and finances without help, and does not experience confusion about time or place. The threshold for concern is functional disruption. The Alzheimer's Association lists 10 warning signs that go beyond speed or frequency: memory loss that disrupts daily life, difficulty planning or solving problems, trouble completing familiar tasks, confusion about time or place, and repeated questions within a single conversation are all indicators that the problem may be more than age-related. Slowing. Getting lost in familiar neighborhoods, struggling with words in speaking or writing, misplacing items and being unable to retrace steps, poor judgment, withdrawal from work or social activities, and changes in mood or personality are also on this list. The unifying feature is impact. If memory issues interfere with independence, or if lapses happen daily or multiple times per week, clinical evaluation is warranted. Occasional retrieval slowness is expected. Repeated disruptive forgetting is not. Primary care physicians use brief cognitive screening tools to establish a baseline when memory complaints arise after age 60. The two most common are the Montreal Cognitive Assessment, known as MoCA, and the Mini Mental State Examination, spelled MMSE. Each test takes about 10 minutes. The MoCA covers executive function, visuospatial skills, short-term memory, attention, and language. The MMSE focuses on orientation, immediate recall, attention, calculation, and delayed recall. Cutoff scores are set by large normative studies. A MoCA score below 26 out of 30 or an MMSE below 24 signals possible impairment. These thresholds are adjusted for education and age, but the principle remains: scores below the cutoff prompt further investigation. When a patient scores in the abnormal range, the physician repeats the test to confirm the result and reviews any factors that might influence performance, such as hearing, language, or fatigue. If the low score persists, the next step is referral to a specialist, usually a memory clinic or neuropsychologist, for comprehensive evaluation. This referral pathway is not a diagnosis. It is a protective measure designed to catch treatable causes, reversible contributors, and early signs of disease before daily function is lost. Clear cutoffs, repeat testing, and timely referral create a safety net without generating unnecessary alarm. Aerobic exercise stands out as the most effective way to slow age-related memory loss. In a JAMA internal medicine trial, adults over 65 walked briskly for 30 minutes, 3 times a week, over a year. Their hippocampal volume increased by 3%, and delayed recall scores improved, while those who only stretched saw no change. These benefits lasted for those who kept up the habit. The prescription is straightforward. Walk briskly for half an hour, 3 days a week. Sleep is just as vital. A Nature Aging study tracked 7,500 older adults and found that sleeping less than 6 hours per night raised the risk of cognitive decline by 30% over 5 years. Deep, uninterrupted sleep helps the brain clear waste and protect neurons. Social ties matter. The Harvard study of adult development found that relationship quality explained 12% of memory differences, outpacing exercise and diet. High social engagement kept memory stable for 6 years longer. Chronic stress raises cortisol, damaging memory. Mindfulness-based stress reduction lowered cortisol by 15% and boosted cognitive scores in a controlled trial. Medical mimics like hypothyroidism, B12 deficiency, depression, medication effects, and sleep apnea affect a third of older adults with memory complaints. Screening and treating these can quickly improve memory. 8 to 12 weeks is the typical window for measurable improvement in memory performance after starting targeted interventions. A systematic review published in Frontiers in Aging Neuroscience in 2022 synthesized results from randomized controlled trials of aerobic exercise, sleep optimization, and stress reduction in adults over 60. The median effect size was 0.3 standard deviations on memory-specific outcomes after 8 to 12 weeks of consistent intervention. This is not a theoretical benefit. It is a quantifiable change, comparable in magnitude to what is seen in many pharmacological trials for mild cognitive impairment. The review included diverse cohorts, confirming that the timeline holds true across different backgrounds and health statuses. Dr. Yakov Stern, a population researcher in cognitive aging, notes, "We see cognitive gains in as little as 2 months, provided the intervention is regular and the dose is adequate." The practical meaning is clear. 3 30-minute sessions of moderate aerobic activity per week, combined with improved sleep and basic stress management, can deliver a real, noticeable improvement in memory within 2 to 3 months. This is the payoff window for patients and families looking for evidence-based hope. The gains are modest but reliable, and they are accessible without prescription drugs or expensive technology. The evidence closes the loop. Measurable change is possible, and the timeline is shorter than many expect. Normal retrieval delays after age 60 reflect hippocampal atrophy measured at 0.5% per year, not imminent decline. Pathological patterns demand clinical evaluation, but daily memory strength improves with consistent aerobic exercise, 7 to 8 hours of sleep, and structured social engagement. Precision, not fear, guides healthy aging.